My name is Catherine Tier. I'm Associate Director of the High Value Care Program at the California Healthcare Foundation, and I'm delighted to see you all here this afternoon. California Healthcare Foundation is an independent philanthropy dedicated to advancing meaningful, measurable change in the way healthcare delivery system serves people in California, particularly people with low incomes and those whose needs are not well met by the status quo. We're based in Oakland, and we have an office here in Sacramento. Our convening today is part of a regular series of briefings we sponsor for Sacramento policy staff and other interested people. And they're designed to bring you information about current issues and trends and to engage dialogue on possible solutions to challenges facing the state. So in addition to all of you here in the room, and welcome, we have about 180 people watching on a live stream and 30 listening via phone. For those of you on the live stream, just a note that you'll have a chance to ask questions during the Q&A portion of the session, and we will, for everybody, be making a video of the session available soon on our website, chcf.org. Before we get started, I want to acknowledge the folks who pulled this all together. My colleagues from California Healthcare Foundation's Sacramento office, our Vice President of External Engagement, Sandra Shuri, and Katie Rodriguez, Crystal Haswell, and Danny Sandoval, who made this all happen, did the heavy lifting, and also Karen Shore and her team from Golden State Health Policy, who pulled together all the logistics. So thanks very much to them. Our topic today is the Drug Medi-Cal Organized Delivery System, or dmc-ods. And I mean no disrespect when I say that if collectively we had known what a great advance this program was going to be, we might have spent a little bit more time on the naming of it. But notwithstanding the name, this is a program that we at CHCF, our colleagues at the state and in the counties, are all really excited about and proud of. DMC-ods is a first-in-the-nation effort to advance substance use disorder treatment through the Medicaid program by providing evidence-based care through a managed system. And as such, it is a really big deal, a really big advancement for California. So our goal today is to give an overview of the program, which is now in its third year, to let you know how it's developing in counties across the state, to hear from an administrator in one early adopter county and a clinician working in another one, to hear from the architects of the program at the Department of Healthcare Services, and to help you just understand the importance of the program to the people in Medi-Cal, which, as you know, covers 1 in 3 Californians and plays an outsized role in the delivery of behavioral health care services, substance use disorder treatment, and mental health care in particular, to people in the state. So to get started, in your packets, those of you who are here in the room, you'll find a paper on the DMC-ods written by the behavioral health team at Harbage Consulting, published by the California Healthcare Foundation this summer, and a couple of short pieces with some quick facts. A card, which I have here somewhere, that will give you a link to all of the behavioral health resources that the California Healthcare Foundation has published recently. A copy of the slides that we'll be using today, and for those of you on the phone, you'll be able to see those if you want at chcf.org/events. You can just find today's event if you want to follow along from where you are, and biographies for our speakers, who I'll just introduce briefly as I go over the agenda. I'm going to give a quick overview for about 10 or 15 minutes, and then I'm going to introduce Jennifer Kent, Director of the Department of Healthcare Services, who will speak about the importance of the Drug Medi-Cal program to Medi-Cal as a whole. We'll then hear from John Connolly, Interim Division Director of Substance Abuse Prevention and Control for LA County Department of Public Health, and also from Dr. Jeffrey DeVito, who's the Chief of Addiction Services for Behavioral Health and Recovery Services in Marin County. Jeff will be joining us via video because he's in Florida attending the American Academy of Addiction Psychiatry meeting right now. So we're very glad to have all these speakers. And then we'll have Q&A featuring both John and Jeff, along with Marlise Perez from the Department of Healthcare Services, who is most directly involved with running this program and building it. So, and then we'll take all your questions. I want to set the stage a little bit. There we go. to talk about why it is so important that we have a Medi-Cal program that can really treat substance use disorder. Substance use disorders are common, chronic, relapsing illnesses for which we have effective treatments. And as this slide shows, we have about 3 million Californians 12 and up by age, about 8.5% of the population who have a substance use disorder. And while we are very aware and hear a lot these days about opioid use disorder and opioid overdose deaths for good reason, it's important to note here and remember that the most common substance use disorder is alcohol use disorder, the orange bar there at about 6.4% of the California population. About 3% of people report meeting the criteria for abuse of or dependence on illicit drugs. It's not on the slide, but the rate of SUD varies quite a bit by age as well, with young adults 18 to 25 having the highest rates, about double that of the statewide average. And most of the use of heavy use of drugs is really starts earlier than that, before the age of 18. So important to think also about age differences when we talk about SUD. So moving to the ODS, what is this system? First of all, it is organized substance use disorder treatment. Important to remember, as I think many of you know, that in Medi-Cal, specialty substance use disorder services like specialty mental health services are delivered at the county level. And what the organized delivery system does is give participating counties the ability and the responsibility to operate as a managed care plan for these services. This is a change. Under the standard drug Medi-Cal program, counties don't have as much control over which providers they contract with, over the rates they set, and Medi-Cal consumers looking for services are largely on their own to find them. So this is providing a single point of entry in an organized system. The second point here is that this is a county-based pilot project under California's Medi-Cal 2020 Section 1115 waiver. Now that's a point that is a lot, I see a number of you nodding to, but for people who aren't as familiar with the waiver system in Medicaid, really what this means is that Medicaid is a state federal contracted program. When a state chooses to do things that are outside of the standard program, one of the ways they do that is by getting a waiver from the federal government. And that's how this program is structured. It's an 1115 demonstration waiver, and really what the state of California is demonstrating here and testing is whether providing organized substance use disorder care to people with Medi-Cal can improve healthcare outcomes and reduce overall healthcare costs. So that's the experiment that we are undertaking here. And finally, we're number one. California is the first state to receive a waiver for such a pilot program in substance use disorder. It's not the only one, as we'll discuss in a second. And here I really want to recognize Marlise Perez and her team at DHCS, who in addition to standing up this program in California, have also been very actively involved in consulting with other states and letting them know how it's been going for us here. So some of those other states are represented on this slide. This is a little bit old. This is as of June, and that shows the states that have substance use disorder waivers in their Medicaid programs. The number has since expanded by another 6 states, and others are pending. This largely reflects national concern about the opioid epidemic and a recognition that state Medicaid programs need to be able to offer a broader range of services with fewer restrictions. So we were first, but we are not the only one. Not every state has a program, though, that's as comprehensive as what we're doing here in the Medi-Cal program. So one thing that the ODS allowed California to do is expand services and expand them a lot. So here you see what's covered by the traditional drug Medi-Cal program. It includes outpatient treatment, residential SUD services, but only for pregnant and parenting women, some medication-assisted treatment, etc. The organized delivery system, however, kept those same services and added a lot more, and I'll call out a few in particular. One is case management, which has been very important to helping people move between systems and move between levels of care. A second is residential services, which are significantly expanded under the ODS, no longer limited to perinatal women, no longer limited to facilities with 16 or fewer beds. Now that, for those of you who are Medicaid wonks is the Institutions for Mental Diseases Exclusion, or IMD exclusion, which from the beginning of the Medicaid program has prohibited the use of federal Medicaid financing for care that's provided to people in larger facilities. There's an exception to the exclusion for people under 18. But it's long been a barrier to efforts to use Medicaid to provide non-hospital inpatient behavioral health services, and the ODS removes that restriction for this program. Another important addition to the services is that all FDA-approved forms of medication-assisted treatment, or MAT, are part of the formulary. So that includes medicines like buprenorphine for opioid use disorder, and disulfiram and acamprosate for alcohol use disorder. And narcotic treatment programs, which traditionally have provided methadone only, now include those services as well. And in addition, naloxone, which is the rescue drug for opioid overdose. So I think some other speakers may say more about the particular services that we've seen expand, but that it is a significant expansion. Another big change in the ODS is that benefits that are offered and the assignment of patients to particular care settings and modalities are based on scientifically validated consistent screening criteria. And in the case of substance use disorder, that is the ASAM criteria, the American Society of Addiction Medicine criteria, which is a little like cancer treatment guidelines in which people are staged, their disease is staged and they're assigned to appropriate treatment levels. That's what we're doing in the organized delivery system with respect to substance use disorder treatment, and that is really a sea change from the way people have typically found their way into levels of care. So I mentioned earlier that this is a pilot program at the county level and that it is voluntary for counties to participate. It's been really, really popular. So on this slide, you see the green counties on the map are those that have already begun treating patients through the organized delivery system. The earliest came online in February 2017, and as of today, there are 22 total counties participating in the ODS. And while they don't make up the majority of the geography of the state, they certainly do make up the majority of the people covered by Medi-Cal. We're currently at about 75% of Medi-Cal beneficiaries covered through this program. And then the gold counties on the map are those that have plans in place to begin implementation of the ODS. So when you add those in, you get to 97% of the total state Medi-Cal population covered by this program. A couple little things to note here. One is that there is a plan to bring a tribal organized delivery system together for Native American and for Native American Medi-Cal beneficiaries, and also the states up at the far north, 8 counties total, along with Solano being one that's kind of not quite in the geography, are working with their Medi-Cal Managed Care Plan, Partnership Health Plan, to administer the organized delivery system on their behalf. So there's a couple of different models. So overall, as I said, Drug Medi-Cal ODS brings substance use disorder treatment into the healthcare mainstream by providing access to a full continuum of services, by acting as a managed care plan, specifically a prepaid inpatient health plan for those services, by coordinating different levels of substance use disorder treatment and coordinating between the substance use disorder treatment system and other healthcare systems, notably mental health and primary care for patients. Counties have increased control. They also have increased accountability. They're subject to the standards in the federal final rule for Medicaid managed care from 2016. And that imposes a lot of requirements around consumer protections, around network adequacy, around quality of care. So as you'll hear from subsequent speakers, this is a big lift for counties to pull all this together and get it up. So is it working? We have a couple of different evaluations underway. One is a statewide evaluation by UCLA, the integrated substance abuse programs there, and then evaluation at the county level by the External Quality Review Organization. So the data that I'm presenting on the next few slides pulls from both of those sources. I mentioned that this is a managed system, and one of the requirements of that is that there's a single point of entry, a toll-free line available 24/7 to people in the county to be screened for care and connected to services. And here's what this looked like in Riverside County in the early months of their implementation. So the small bars on the left was when the phone line existed, but it was sort of in beta testing mode and not being advertised. The bars on the right show what happened when the system really came online and was advertised. And while certainly everyone expected to see an increase in the number of calls coming in, I think the size of the effect was beyond expectation, and really speaks to the depth of the need for these services and people's real interest in getting into substance use disorder treatment. As far as numbers of people served, this data is from the recent UCLA evaluation published just a few weeks ago. It shows how many people were served by the counties in question both before and after ODS implementation. They looked only at those that were already active as of mid-2017, so that's why there are not 22 counties up there, but a smaller number. And compared to December 2016, by the end of 2017, those counties that were live had increased the number of patients being served, here's the overall bar chart, by 28%. So a really significant increase. Now, important to say that some of those people might have been receiving services through other funding sources earlier. So that total increase in the number of unique individuals served is somewhere between 7 and 10%. There's some county data that's a little funky, so it's the higher number if that county is excluded. But either way you count it, we are seeing an upward trend in the number of people receiving substance use disorder treatment services, and I suspect when we have a lot more data in a year with many more counties online, we'll continue to see that increase. Other impacts are also positive. We see improvements in access, in engagement, and satisfaction. So the access I mentioned, but it depends on the modality of treatment, sort of what has increased the most. So there has been a particularly notable increase in people's access to residential treatment, and I think some of the subsequent speakers can go into that a little more. There has also been really positive impact on treatment engagement, which is measured as the number of people who have 2 additional SUD treatments after a first contact, meaning they stay in treatment. And again, that varies depending on the modality of treatment, but it's at least as good as we could have expected based on the literature. And finally, very importantly, satisfaction. People who are receiving treatment services under the drug Medi-Cal organized delivery system are very pleased with what they are getting. We're seeing 93% positive ratings of the treatment received. So, all that said, many continuing challenges, and I'll mention them quickly. We can talk about them more in the Q&A. We need to continue to improve administrative infrastructure, both at the county level and for providers. This is a big lift on both sides to operate in this organized way, and documentation, billing systems, data sharing, all of those are very real challenges. Workforce. At both the level of addiction medicine, which I think Dr. DeVito will talk a little bit more about, down to entry-level substance use disorder counselors, this is not a workforce that we have enough of, and we need to continue that development. Another thing is access to medication-assisted treatment, which I mentioned briefly. We continue to need more training for providers, more access points in order to get this treatment available, which really is the state-of-the-art for opioid use disorder in particular. Access to youth, I mentioned at the beginning the demographics, but that's the place that across the state we tend to fall short in terms of having sufficient treatment slots. And finally, coordination across systems with the mental health and the primary care systems, with the criminal justice system, and transitions along the continuum of care so that people having received one level of care are appropriately switched to something that might be a lower level as their needs changed, or a higher level. So I hope that's been a good, if quick, level-setting overview. The other speakers will provide more context on their own counties and on the details. But I first want to ask Jennifer Kent, Director of the Department of Healthcare Services, to offer some reflections on what I've presented and some additional remarks. Thanks.
So good afternoon. I think, you always do such a nice job of kind of laying out all the work that Marlies has done. But I want to just say that you look at the history of what has happened in our program, and really there's only a few times in which there are policy windows that are open, in which you have a collision of events or circumstances in which you're actually able to advance pretty significant either policy goals or objectives. And I stepped back prior to when I joined the department back in December of I joined in February of 2015, but if you step back all the way to 2013 and all the way back even to 2010 with the passage of the Affordable Care Act, and you think through all the different things that had to happen to get us to the point that we're in and the implementation of the waiver, we had some issues in the drug Medi-Cal program as it pertained to provider fraud. So that's like a negative thing, right? That was a very uncomfortable, unpleasant thing that we had to deal with. And when we were dealing with that as a state and as a department, we said, wow, how could we do this better? And then you get to a waiver where you were like, how about if we do something that is more organized, more coordinated, that has contracts in place, better oversight, better accountability, that might actually not only benefit the beneficiaries, but will also help strengthen our overall program integrity efforts. And so out of that were kind of the two seminal things that help drive some of the creation of the waiver. You overlay the Affordable Care Act, and you cannot diminish the magnification of what the federal financing has meant for this program and for access to these beneficiaries. So I was sharing some statistics with Catherine beforehand, and I like to do this, is I look at how counties have financed their share of the ODS waiver since they've gone live. And I'm doing very kind of snapshot, but for Riverside, who was one of our first counties that went live on the waiver, when I kind of did a cut from February of 2017 through, or 2016, February 2016, 17, okay, February 2017 through June of this year, they'd only spent 2.1 million of their own money. The state had put in about 4.5 million, but they'd done over $33 million worth of services. And so the magnification of what the county has put in to provide services, when you compare it to what the state and then the federal government is, cannot be understated from the standpoint that that has allowed so many more services and so much better access for beneficiaries. I think the other thing, when you take all of those different kind of policy initiatives and changes, there's been a lot more both awareness and intersection between our program and the criminal justice program. There are populations that are cycling through either jails or correctional facilities, and a lot of those instances are driven by addiction or somehow related to an addiction issue. And I think we have really been working as a state to try to both understand how we can better prevent that from occurring, but also make sure that when we are transitioning populations out of correctional settings, that they have something to step into and hopefully prevent that from occurring. I was at an event last night, and we were with a group that provides substance use treatment to children and to youth. And it was interesting because the person said it so well. He said, when you have an addiction, or when you're struggling with an addiction, it crowds out everything else. You cannot focus on your health. You cannot focus on your education. You cannot focus on your children or your job or anything else. It crowds everything out. And I think the creation of the DMC-ODS waiver in some cases is our effort as a state to say, we acknowledge that that is an issue. We acknowledge that it prevents people from doing things that would otherwise make them successful. And so the creation of a delivery system is really intended to also help drive other societal changes that we are hoping to see. We want to see fewer people arrested. We want to see fewer children in the child welfare system. We want to see fewer overdoses. We want to see fewer negative outcomes. And so this waiver is really our best way of helping to both equalize and acknowledge the struggles that people have with addiction, and understanding that that has very much a very real impact on how their primary care and other types of social and human services are impacted. So I would say the last, before I close, we have waivers that run in 5-year increments. So this waiver was done in August of 2015. Remembering my dates, looking for my lifeline. and expires in December of 2020. And a lot of people are nervous. I know the counties were certainly nervous, which is we don't want to build this infrastructure. We don't want to contract with these providers. We don't want to provide services to beneficiaries if we think it's going to all go away on December 31st of 2020. And what we have said all along is, A, we're very proud of it. B, we think there's a lot of other people that are proud of it, meaning the counties are proud of what they have been doing. We could not have done it without partners like the California Healthcare Foundation. But more importantly, I think it's also a point with pride from a federal perspective. This, as you noted, we were the first state to do it, but other states have started to reflect and do similar initiatives. And I think it's a broader recognition of the importance that we as a state have to pay to those with addiction issues. And so we have every intention as a state in seeking to continue this past December of 2020. And so, stay tuned, but it's certainly our interest and acknowledgement that this is basically a process and a program and a delivery system that we have built for the long haul, meaning we hope to, change permanently trajectories of people's lives and improve them in a way that drives, better quality, lowers overall unnecessary healthcare costs. So with that, I'm very, very thankful that we've had such great partnership with the foundation, because in many cases, for as hard as we've worked as a state and as hard as the counties have worked to implement this, there are a lot of things that we could not have done without the foundation and all the technical assistance that's come to both us as well as the providers in the counties. So with that, I will also say thank you very much, and I appreciate you having us.
Thanks. We're going to be a little bit up and down today because we have different speakers standing in different places. But I now want to introduce two people. Well, I'll introduce one and then the next, who are speaking from the county perspective. So first, we're going to hear from John Connolly, Interim Division Director of Substance Abuse Prevention and Control at LA County Department of Public Health. And then, as I said, Dr. Jeffrey DeVito, who's the Chief of Addiction Services for the Behavioral Health and Recovery Services in Marin County Department of Health and Human Services. So they're both, they come from different perspectives on this. Both of these are counties that started in the first year of the drug Medi-Cal organized delivery system. One very big, one not so big, but we're really glad to have both of them here to speak. And so I'll turn it over to John.
Yeah, let's do that. That's better. I'm going to take the mic. So thank you, Catherine. Thank you to the foundation for having me. It's good to see everybody here. I see a lot of familiar faces. Glad to be here to share what our experience has been and to talk about our partnership with the department here in Sacramento. I think it's been a really fruitful one, and I think we're very excited about the distance that we've covered and what we still are planning to do. So as Catherine said, I'm John Connolly. I'm the Interim Division Director over Substance Abuse Prevention and Control. We are within the Department of Public Health in Los Angeles County, and we are part of the broader health agency, which includes Health Services, which is primarily responsible for our public hospitals and comprehensive primary care centers, the Department of Mental Health, and also Public Health, which is where we reside. Oh, sorry. There we go. All right, so I chose some baseball metaphors here. I think I was doing this toward the end of the season, so bear with me on that one, but I think it's apt. So I always start, and I'm going to reiterate what Catherine said by saying it's hard to overstate how big of a deal this is. So I think it's both a watershed moment for the Medi-Cal program, but also for healthcare more generally, because the big idea behind this is that we're redefining substance use disorders as healthcare, not a moral failing, not a criminal justice issue, but primarily a healthcare issue. And by providing comprehensive, meaningful, recovery supportive services to people, we're basically putting our money and our actions where our mouth is with that. And so I think that is kind of the big underlying principle behind this. And though I'm going to talk about some of the financial nuts and bolts here, and the administrative pieces that we put in place to make this work, I think that's the one thing that I want to make sure that I reemphasize before I dive in. The other disclaimer that I'd offer is that though I have a PhD, I'm not a clinician, so I'm really the policy and finance guy as a part of this panel. And so my perspective is mainly one that focuses on kind of how to make this work from a Medi-Cal financing and managed care perspective. So that said, I want to start with excuse me, the work that we did internally to become not just a division of a public health department, but actually a specialty Medi-Cal managed care plan. So that work was tremendous, and it's ongoing, and requires a few different things that the department set out in its terms and conditions for the waiver. So basically the things that you are required to do as a county to make this work. So the first thing is, in a county the size of Los Angeles, the task of authorizing residential treatment, every single admission into a residential facility was something we had to tackle right away. It was a non-negotiable and something that we wanted to do to make sure that people got the right care in the right place at the right time. And so we had to make a decision, as many counties did, about how do you do this? Do you hire a third-party administrator, somebody from the outside to handle this paperwork for you? We decided actually to hire our own clinical staff to do this work and to structure it internally and to refine and design the workflows. But it's a huge, I think, lift both internally, or even if you're overseeing an external entity to do that work. It also, and I will lean into this point, is very, very important that you prepare your providers and your clinicians for this kind of process. Because not only were our contractors, our treatment providers, not used to a managed care system, they were also not used to Medi-Cal. So the majority of our services were billed and delivered outside of the Medi-Cal program. Medi-Cal is now the primary payer in our system. So to get them used to this and to get them trained and savvy about this process and making sure that they are persuasive at times about what level of care a patient needs, and to be, kind of very, I think very detailed in some respects, not just to say this person's been using meth consistently for, this time period, but be a little bit more specific about what the needs and the issues the person is confronting are. So that's been, I think, one huge piece of this. In addition, documentation. So we're requiring different, and I'll spare the acronyms and details, but different formats with regard to documentation. This, again, is something that we've kind of imported from the mental health system that, again, for many of our providers was new and presented, I think, a set of new expectations that was difficult. So many of our providers continue to tell us in our listening sessions after the first year of implementing this waiver, it's very difficult, as Catherine said, with the workforce, to have the counselor that is both terrific in front of a group, has those interpersonal skills, but also is really good at documentation and describing what services were delivered for how long, the needs and the types of interactions that occurred, that sort of thing. Lots of technical assistance and training that we're actually providing to our network through a contract with the California Institute for Behavioral Health Solutions. So not an easy lift there either. In addition, new functions that we built, I think, by requesting from our very supportive Board of Supervisors different budgeted items that are doing completely new things that we've never done before. So things like beneficiary relations. There are a number of requirements, not only of the department at the state level, but also the federal government under the new set of Medi-Cal or Medicaid managed care regulations, requiring us to inform beneficiaries of their rights, to notify them of an adverse service decision, for example, if they're denied authorization to residential and feel that they need it. Lots of different patient manuals and handbooks in the 13 different languages that we have to translate them into in Los Angeles County. Provider relations. So like I said, we have a large technical assistance contract with the California CIBHS, California Institute for Behavioral Health Solutions, but we also have staff now that are providing a lot of technical support to providers. We also, in our excitement about launching this, implemented a new electronic health record because this was, this wasn't complex enough to begin with. So lots of, I think, at the elbow support needing to be provided to our providers who have stuck with us for the most part, and really, I think, made a great deal of progress in serving patients with all of the new tools at their disposal. And of course, completely overhauling the oversight and monitoring procedures that we had in place before. So with this, new services, new systems, new policies, procedures, we had to train our staff to go out and make sure that all of these things were in place at the provider sites. So no simple task there either. Jennifer and Catherine also mentioned the financing. I also want to reiterate that point. We are so grateful because of the financing provided through the federal government and the state from the general fund to provide more services for more people. And some of the traditional funding sources that we leaned on that supported our treatment services 100%, we're now able to repurpose for a variety of different things. Navigators out in the community to engage and refer people into treatment. We're paying for room and board for dependents in pregnant and parenting women facilities. We're reinvesting or investing more in prevention, which is something we think is sorely needed in our county. So lots of creative ideas that I think are very valuable, and making sure that we're also tackling things more upstream and providing, wraparound services around the expanded DMC-ODS benefits package, just trying to make sure that we're listening to what issues the communities are dealing with and reinvesting or redirecting the money in a way that I think truly meets their needs. I think the other thing, too, is that we've learned that more and more clinical issues are financial issues. So if, for example, the number of groups that different clinicians are able to handle and document for is challenging, that affects their level of billing. So all of these new requirements posed a lot of challenges in terms of productivity for the providers. So helping them through that, just think through their business and clinical processes, because again, if you can't serve people in a more volume-specific or fee-for-service environment, your revenue will suffer. So explaining that and making that work for our providers was a process, and all of that continues. I think the other thing too is, and again, for those of you who are more in the kind of the details of these waiver projects, we made a decision, whereas previously we had different specific contracts for different people. So a CalWorks beneficiary, someone who was served in an AB 109 program, someone served in the county's general relief program for people who are homeless cash assistants, essentially. We unified the contract under a DMC or a Medi-Cal chassis. So basically, everybody gets the same benefits package. If they qualify for Medi-Cal, obviously we submit the claim to the state under the financing that the state and the federal government provide. If they're not qualifying for those programs, we would serve them through a different funding source, but basically standardizing and streamlining for the providers to make this work, but to hold them to that similar standard to have basically a managed care benefits package. This is one of my favorites. This is my fruit salad slide. So I'll dedicate this one to Norman, because he's a fan of fruit salad. We were chatting at the beginning. So basically, before that was our financing and contracts. Now we move to the kind of apple, Golden Delicious or Granny Smith, I'm not sure from this angle, with the Red Delicious being other funding sources outside of Medi-Cal. So it's a much more streamlined and expansive benefits package. And I think we're really proud of the fact that we're serving a lot more people with a much bigger benefits package, including recovery support services, now under this kind of this structure. I just want to say a couple of things about the front doors to our system. So as Catherine said, as the state required, we have a 24/7 substance abuse service helpline, the SASH, because we need a snappy name. That's our number in case you want to call and get some information. And what you can do is, if you're looking for treatment for a loved one or for yourself, you can call the number anytime. There will be a substance use counselor or a licensed clinician on the other end of that line to either provide you with information or a brief 15-minute screening. So this, like the full American Society of Addiction Medicine assessment, is based on ASAM principles and will give you a provisional level of care within 15 minutes. Then what will happen is the counselor will call one of our contracted providers, their admission staff, and basically make you an appointment right then. And they'll say, okay, next Tuesday, this provider who speaks your language, let's say serves pregnant and parenting women or adolescents, whatever group you're a member of, and need the provider to be cognizant of, they will basically make an appointment for you during that call. And then you can then go to the provider and be assured of an appointment for admission at that time. So that's basically what happens with the Substance Abuse Service Helpline. We have client engagement and navigation services, or SENS as we call them. It's a French pronunciation. It's a joke. That was bad. Anyway, so we have roughly 70 co-locations serving basically the same function that the SASH performs at the call center in different places around the county. So that could be courts, psych urgent cares, EDs, probation hubs, etc. So they're catching people in those places right away. The jail reentry center, for example, referring to treatment in that place, providing the brief assessment, contacting the provider, and making sure that folks are getting an appointment, and then follow up afterward in this model to see whether or not they kept the appointment, and then try to contact the patient to be sure that they get there eventually if they need to reschedule. Additionally, because there are folkways in the communities that providers serve, we still have not gotten in the way of a direct-to-provider entry. So if somebody just wants to go to a provider site and initiate treatment, have an assessment, they can do that still. Okay, another acronym. This is the Service and Bed Availability Tool. I think this is very cool, and I hope you do too. We're very proud of this. So we call this the SBAT, maybe on the baseball theme, I'm not sure. So this is sort of basically a service locator. And what we have there is a map. If you search by a variety of different criteria, it could be level of care, different types of groups served, again, what languages you speak, etc. And you can filter it by all of those over on the left. Then you'll get a populated map that will show you where those providers are, and then a list of them down below. And what we think is particularly cool is if you search for a residential treatment level of care, you will find out if there are available beds in this column here, how many, and for men or women. So you know if you click on that provider that day whether or not there are beds available. And providers are contractually required to update this every day. So we think that's a really good advance for the system, such that the public and those in the call center and in the SENS navigator kind of core know what's available at that time. In addition, for outpatient, we later added a capability such that you would know whether or not outpatient providers had appointments within the next 5 days. So that was also, I think, very helpful for people who ended up needing an outpatient level of treatment. So I think with that, I will wrap up. I had about a minute left, so I'm right on time. And with that, I'll hand it back to Catherine for the remaining presentations.
Thank you, John. It looks like our system is working for this remote presentation by Dr. Jeff DeVito from Marin County. So I thank you, Jeff, for being able to join us from Florida, and we'll let you take it from here.
The funny thing about this interface is that on one hand, I feel like I'm sort of like on CNN, you know, where they like remote the person in from some other, you know, strange location. And on the other hand, it's great because you know, I'm just going to assume that everyone's laughing at every joke that I've made, and that I'm really just killing it up here because I can't see anything that is happening there. So I'm going to assume that things are going well. To that end, though, I do want to thank you know, Danny and Crystal and Catherine for making this happen. They asked me to participate in this, and I was eager to help. The only problem being that I needed to be in Florida this week for the AAAP conference, and they managed to set this up. So major thanks to them. The other group or the other people that I want to just call out, because in some respects I feel like I'm kind of here presenting on something that by and large was developed, you know, independent of me. So I can't take great credit for this. But Catherine Condon and DJ Pierce, who's now retired from Marin County, and our whole team there, Cody Milner, Lee Steffi, Jordan Hall, you know, I just need to give them credit because they were the ones that really put Marin's foot in the door with this, which has been just a huge boon for me stepping into the county as a clinician and trying to then kind of see, well, what can we do to enhance the services that are being provided with this as the framework. So my understanding is that people have my slides either being displayed or, you know, have them on hand. I can't see either, so I'll just kind of talk it through. And I know Danny's been, you know, instructing me that he'll be helpful in kind of advancing the slide. So I'm assuming that right now you're probably looking at my first slide, which says DMC-ODS waiver. There's my name. I don't think there's much more to say about that slide. You're moving on to the next slide, which is expanding the continuum in Marin. That's the title of this slide. I wanted to highlight a few things. Again, I'm going to try to look at this from the perspective of a clinician. As was mentioned before, you know, by training, am an adult psychiatrist. I then did fellowship in addiction psychiatry, and I've subsequently also got boarded in addiction medicine. And I mean, I was going to make a joke about, well, I hope I have some relevance to addiction psychiatry since I came all the way to Florida for a conference about addiction psychiatry. Good, I'm in the right spot. The interesting thing about this, for me as a clinician is kind of being able to kind of have a foot in both worlds. On one hand, kind of being able to pick the brains of the people who created the system in Marin, and then on the other hand, kind of looking at and knowing a little bit about sort of on the clinician level how the system either is seen or how it works for people, or how it historically has not worked for people, let's say. So just to highlight some important additions around the continuum in Marin. And then what I'm going to do is I'm going to talk a little bit about sort of the expansion piece, and then I'm going to talk a little, and then I'm going to kind of work through a flow chart of, a fictional character, let's say, in Marin County, and kind of show where some of these things might play out clinically for someone's experience. So in terms of important additions, as was mentioned earlier, the expansion and the opportunity for providing residential treatment is huge. That's historically been a bottleneck place for a lot of, a continuum of services. In Marin, we were fortunate that we're sort of, we are a small county, certainly relative to Los Angeles County, but we are kind of adjacent to counties that are bigger, so we do have access to different things, and we can model more closely, I think, based on our experience around us. But we were able to add, an additional 2 residential programs, which was great. So we originally had 1 residential program, and we expanded that to 3. We were, as has been mentioned already, we were able to kind of use this as a springboard for facilitating an integrated access point for county mental health and substance use services. So in Marin, we basically took the the Behavioral Health and Recovery Services access line for mental health services and specialty mental health services, and we combined that with substance use service evaluation capacity as well. So 24/7 people can call our behavioral health access number and receive an evaluation that will also, will on one hand produce an evaluation of one's mental health needs, but then we'll also be able to evaluate based on ASAM criteria what their substance use services may be. That being said, one need not go through the access point to access services for substance use services, as was mentioned, before. We also preserved the ability to kind of go directly to services if you wanted to, directly to our contracted providers. So that was a huge addition. Our access center also has walk-in hours. So people can come during walk-in hours and get an in-person evaluation on the spot if that's a desired route to get into services. The huge thing that we really, again, I can't take credit for this. The wheels started spinning on this before I came into the county a couple of years ago, was that historically Marin County had not been in the business of direct service for substance use services. And with the advent of the ODS, we were able to provide what we call the Road to Recovery program. And the Road to Recovery program specifically has been designed to provide direct services to county Medi-Cal beneficiaries via county employees. So it's not a contracted out service. The goal of this was really to provide services for co-occurring disorders. And this is, it is a service that gets referred to, clients get referred into it via our specialty mental health services, and they work very closely with with our behavioral health group as well. The other huge expansion, I think I'm probably just going to say huge about each one of these, because I do think that each one of these is in fact a huge addition. Being able to bring in more recovery services and in specific more recovery coaches for us has been a huge boon. We historically had used recovery coaches only in conjunction with criminal justice involved clients. But now to be able to provide those recovery services, those recovery coach services outside of just that, someone that's involved in the criminal justice system has been a huge addition. And I'll talk about kind of how that plays out. But the idea about the recovery coaches is that because when I was in training, I didn't really get taught too much about recovery coaches. In academia, that's not something we really spend a lot of time on. For reasons I'm not going to go into here, but the fascinating thing for me as a clinician is that the recovery coaches provide a degree of flexibility and nimbleness to be able to kind of reach out and find people and see people in venues that otherwise we'd have a lot of trouble reaching. So they've been really a great resource to kind of lean on when we're trying to think about some of those clients that are having difficulties getting in despite the fact that we have all these open access points. In addition to that, and this is just sort of one of the things that I think is a huge boon to efficiency, when we opened up, for example, like the Road to Recovery program, historically, medical necessity in a program like that would have had to have been attested to by an MD, i.e. someone like me, and being able to instead have LPHAs provide or attest to medical necessity has been a huge benefit because it's just more efficient because the LPHAs are actually in the clinic on a day-to-day basis, seeing all the clients. They know the situations very well. To otherwise require the LPHA to then present it to an MD, some doofus like me that might not be there, might not know the client, and then they have to present it all to me in order for me to attest to the medical necessity, just decreased on efficiency. So having the LPHAs be able to do that was actually a huge boon. The other huge boon was being able to expand the options for withdrawal management. From a clinical standpoint, what this meant was that we could have people engaged in withdrawal management services at our local narcotic treatment program over a longer period of time. And the general adage from a clinical standpoint in addictions is the longer that you can keep somebody in treatment, the better they might do overall. So even if you're kind of designating them under withdrawal management, you're keeping them in treatment longer. In conjunction with that, being able to have expanded MAT services, and in particular, I've singled out here the expansion in NTPs being able to provide additional MAT services, which has dovetailed very nicely with the Hub and Spoke program, which is a separate grant from DHCS. And people who know me know that I can kind of keep going and talk all day long. So I do want to kind of rein myself in a little bit, especially because I can't see anybody's faces to see if everybody's already asleep. But I do want to kind of keep moving on this. As was highlighted in the beginning, I think that the first thing that was mentioned in terms of the very first presentation about the major changes that arrived with the DMC-ODS waiver was case management, and that has been no exception in Marin County. Being able to provide case management has been invaluable because that allows us to try to actually work around breaking down some of the silos between different systems that we have. That allows our folks, our county folks, basically to make those critical connections that we need to make, and that has played out very effectively. It's also provided, the way I like to describe it is that by enhancing the continuum of care that we're able to provide in the Medi-Cal system for our community has provided a foundation around which then we can spread out and be able to explore relationships more closely with criminal justice, with public health, with emergency medical services, and I'll talk about a few of those now in my last slide here. Now, again, I don't know what people are seeing in front of them, but I'm very proud of having put together a very elaborate flow chart that involves multiple colors and multiple arrows, and I'm just marveling at it here, thinking that I was actually even able to accomplish this.
And Jeff, I'm going to jump in. This is Catherine, just to say that I've got to apologize because we don't have the slide up on the screen, but people are following along on paper, but the animation will be lost on us.
Oh, perfect.
So just talk us through it.
Good. Yep, you bet. Okay, thank you. That was an invaluable piece of advice to guide me through this. So I'm going to start with, this is obviously all fictitious, but I kind of tried to create a scenario that showed clinically the pathway Bob, a 45-year-old man, might have, and some of the areas in which the ODS has kind of expanded what we're able to offer Bob, ultimately leading to potentially a place of better chance of recovery. So Bob's a heroin user in Marin County. I'm just going to limit it to heroin for the time being. But as we all know, it's probably much more complicated than that. Bob is fortunately connected with an FQHC provider. Now, the FQHC provider sees Bob one day and notices the track marks and says, I'm wondering if maybe you have, some issues around substance use that you might want to talk about. Primary care provider figures out that Bob is actually using heroin. So what does the PCP provider do? The PCP provider says, hey, I remember something about this. This is a Medi-Cal beneficiary. All they need to do is go to Access. So gives the person the phone number to Access. Again, remember our Access services are now consolidated, courtesy of courtesy of the ODS waiver. So PCP says, okay, this is simple. There's one access point, 24/7. Let's refer Bob there. So Bob goes there. Bob gets an assessment. Let's say he physically shows up. He gets an assessment. The assessment comes back with, ACM assessment is done. Referral is made to our local narcotic treatment program, Marin Treatment Center. So he shows up at the Marin Treatment Center, and at Marin Treatment Center, they offer him maintenance, let's say methadone or Suboxone. He's not really into that at this point. He's not ready to commit to maintenance, but conceptually, he's like, I could go for a protractor. If you've got something that will help me detox over a longer period, I could totally go for that. So we say, oh, well, that's great. Well, we'll put you into withdrawal management. So Bob then gets plugged in with withdrawal management, and he stays at Marin Treatment Center, let's say, for 45 days now, where he's able to go through a nice, slow, safe taper, during which time he gets contact points with Marin Treatment Center, establishes a couple relationships, let's say. He finally finishes that, and he leaves the narcotic treatment program, and as we know from national data, statistically, many of those folks relapse. Bob relapses and he overdoses. He's picked up by emergency medical services. Emergency medical services brings him to the local emergency room where he's revived on Narcan and then released. However, in that process, EMS has alerted our public health group under Matt Willis, who's been a wonderful partner for us with kind of thinking about these strategic things. EMS shares the data with public health. Public health then shares that data with an outreach, with a telehealth outreach company called Bright Heart Health, who then will do outreach via contact information that were provided to Bob. So Bright Heart's, finding Bob. This is what I've sort of encapsulated here on the slide as the public health intervention. When Bright Heart Health finds him, though, what they determine is that now he lives in West Marin. So for people that are familiar with Marin County, we have sort of like a divide in Marin County. There's sort of the rural west part of the county, and then there's the sort of more suburban / urban / hot tub part of the county, which is, along the 101 corridor. And we have a lot of trouble reaching people in the western part of the county. So the good news is that now, courtesy of the ODS waiver, we can provide remote services to West Marin. So because Marin Treatment Center, our narcotic treatment program, is a DMC certified site, they are able to provide telehealth services themselves out to West Marin. So the NTP referral is made again. At that point, then, he is then connected to our Road to Recovery program because in the process, they've also referred him to County Mental Health, where he's determined to also have schizophrenia. So now County Mental Health, Road to Recovery are now both involved on Bob's care. He's getting remote services onto the western part of the state, and then Marin Treatment Center starts him on Suboxone, which, again, through courtesy of the ODS expansion, allows him to get onto a maintenance medication and finds him where he's at and allows him to continue that at that time. In the process, he's getting a recovery coach that's helping him navigate and bringing him to some of these appointments and getting him to some of the things that he needs to get to. So again, I wanted to highlight just kind of how the continuum of services could play out in someone like Bob. And as a clinician, I can tell you that this scenario of Bob being interested in certain services, not interested in others, the challenges of other providers in figuring out how to refer somebody into treatment, all of these things are, and then having somebody navigate kind of how to put all these pieces together. Again, that was facilitated by the formation of a stronger foundation through the ODS system. So again, I wanted to focus on the positive aspects. There are still challenges, of course, with as with any program. And if those are specific things that come up in the Q&A, I'm happy to address those. But I kind of wanted to focus on the positive sides of this.
So I'm gonna kick off though first with a question. First, I want to introduce John. You all met already, but I really wanted to introduce, since she's now up in front of the room, Marlise Perez, who is the Division Chief for Substance Use Disorder Compliance with the Department of Healthcare Services. So welcome to Marlise, who knows all about this program and will be happy to answer questions. So let me ask you first, though, Marlise. I gave a little bit of an overview of what we've seen from the UCLA evaluation in particular, but can you talk more about what you're seeing and what's interesting to you or concerning to you from the various evaluations, both the statewide evaluation from UCLA and the work that the External Quality Review Organization has been doing?
Great. Thank you, Catherine. Yes, so I think what's a little bit challenging with the ODS, but after hearing from LA and Marin, I think you might have a better understanding why, is because of such a huge system lift. We recognized at the state that we couldn't roll everybody out at the same time. That was just physically impossible for us at the state level. So we broke it up into phases. And so what you're really seeing today is work from some of our Phase 1 and Phase 2 counties. And you'll also see that through the UCLA evaluation and then also the work done by our External Quality Review Organization, because all counties, once they're live for a year, they have a visit from the EQRO. And so really the difference is they come in at the system level to see in areas of access, quality, measures like that, how they're doing at the county level. There's different performance measures around these areas. And so there's a lot of detailed information about each county. But what we're seeing from a broader level in areas where we need to really think about how we can improve are those transitions. So you heard a lot about the 24-hour access line, getting folks into the system that we're really, really excited about. Obviously, such a change for the counties and putting all of these pieces into place. But also, it's a huge mind shift. And so it's been really interesting over the last 3 years to see counties make that mind shift into that managed care system. This is the first time that substance use disorders for California and really pretty much in a lot of states are managed care systems. And so that is way different than before. Before, someone would go into a provider, get some services, and leave. And the county, while they'd be responsible to pay for those services and oversee those services, they weren't necessarily feeling, I'm responsible for that person, period. They're in my county, and knowing that a substance use disorder relapse is a part of the disease. And so I think that has been such a huge shift. So you'll see through the third year of the UCLA evaluation, there's still struggles with these transitions, moving through these levels of care. How are handoffs being handled? So I think that we're going to continue to see that, and we're hearing that a lot from the providers. It really is such a big shift. So I think that is something that we're really looking at. How can we make more of those transitions and seamless for the patients themselves?
Thanks. I think we'll open up to questions from the room or from folks who are on the live stream now.
Hi there. We have a question from the live stream. This one's directed at John Connolly. I think Jeff DeVito touched on this, but the question is, you mentioned the emergency department accesses the SUD system, but can you expand and talk about exactly how that connection happens, the ED, the SUD system? You had some some items on your flowchart.
Sure. So a couple of things are going on related to emergency department work, and I think the portion of that I was speaking about in my presentation was related to the Client Engagement and Navigation Service, or CENS. And basically what we do is we have 8 contracted providers who are out in a variety of different emergency departments in different hospitals, both county and private hospitals, and they're roaming basically to accept referrals from clinicians in the ED. And if someone comes in, let's say, with an overdose or a variety of different issues that brought them to the ED, whether they be primarily substance use related or not, but if they need a screening and a referral to one of our treatment providers, the navigator, who is a substance use counselor, in most cases, sometimes an LCSW, a social worker, or a marriage and family therapist, will do the screening, call the provider, get the appointment, and make the connection. I think another new initiative that's very exciting in a couple of hospitals, I think one for those of you who are familiar with LA, realizing I'm in Northern California here, in the San Fernando Valley, as well as up in the Antelope Valley, which is the far northern rural portion of the county. We do have rural parts of the county actually in LA. There will be overnight services provided by those navigators. So if someone comes in at 2 a.m. and needs a referral to a provider, we are engaging one of our largest providers to offer admission overnight, even if somebody needs urgent services right away. So that includes withdrawal management as well as admissions into residential if that's what's needed, or the preference of the patient, I think. So, because obviously willingness to engage in treatment is a part of that. I think the last thing I would mention is that, particularly within the county-operated public hospitals in Los Angeles County, our Department of Health Services is very engaged in creating more opportunities to engage folks who come to their emergency departments, both in medication-assisted treatment. So their physicians, their prescribers are becoming much savvier about and educated about prescribing different forms of medications for addiction treatment, but also continuing community-based treatment in our network, which now includes several of their primary care facilities, which are now DMC certified. So if someone's impaneled in one of their facilities and visits their ED, they can receive ongoing treatment within our public Department of Health Services system. So lots of exciting work going on, I think, in different EDs in LA County.
So I have a question about workforce. I'm a provider in 3 counties, and I think I want to pick up on a word that you used, Marlise, which is about mindset. And the challenge is with the workforce, and the existing workforce primarily has as its reference point its own successful recovery that was done largely in social model, that was authority-based, rules-based, and trying to transform and train them to understand neurology, psychiatry, the behavioral sciences, evidence-based interventions, training to fidelity, and delivering services that way is a huge challenge. And so my question is about workforce development, the existing workforce that is operating out of an old paradigm. How do we assist them working in this paradigm? And then are we doing enough with universities, community colleges, credentialing programs to train a more scientifically minded workforce?
John Saul, you want to take this? Sure. I have no one to pass it to over here. I should have sat in the middle. Anyway, no, workforce, thank you for bringing that up. It is a huge issue, and I know it was like 3 times on Catherine's slide. And so we really, when we were developing the waiver, and DHCS gets a lot of credit, but I like to remind everybody that everybody was in the room. We did like 9 in-person all-day meetings, and it really was a brain trust, and workforce kept coming up. And so we put some things into the waiver that we knew would be helpful, but as we've been rolling it out and talking to other county leaders, it is, and training about ASAM, because ASAM is far more than a placement tool. It's a whole philosophy with dimensions of care, and it really individualizes treatment. So the days of the cookie cutter, where somebody comes in and you do the same curriculum with the same people, you can't do that anymore. And so we've heard a lot from counties. Counties have been investing a lot of time and resources into training. The state has been investing a lot of time and resources into training, ASAM being one of them, because we really feel that if you can help a counselor understand the tenets of ASAM and really apply that, that can be a huge shift. But there's also been a lot of work recently done by our legislature to pass some new laws that are going to be coming into effect in January around medication-assisted treatment. Unfortunately, there's been a lot of stigma in some of our treatment providers around not just our workforce, but in providers themselves, and not allowing individuals that need the medication to be at their facility. So there's a lot of things working in play all at once. I definitely think there's a long way to go when it comes to workforce. We are utilizing at the department some other funding that we're exploring a project with residencies, residency programs to really teach them not only about opioid use disorder, but substance use disorders in general. So I think it's going to be a long haul when it comes to workforce, but we're continuing to take strides forward because it's going to be those individuals that are meeting one-on-one with the client or in a group setting that are really going to make the difference. So I'm also going to turn this back to John in case he has something he wants to add.
I think that was a really comprehensive answer. The only thing I would add to that, thank you for asking that. I mean, it's a tremendously foundational issue for us. And I think what we're mindful of is, on the one hand, we want to maintain that experience-based and recovery-based model that's really valuable. That lived experience that many bring to group when they lead group is really important. But to also add some of the new kind of documentation requirements and the advanced kind of evidence-based practices like motivational interviewing, cognitive behavioral therapy, things that are required as a part of the waiver to broaden their toolkit. So it's a heavy lift. Thanks for asking that.
And I should note too that that Dr. DeVito, I think, is still available for questions, and so I wonder, do you want to weigh in on that from your perspective?
Well, I mean, I think it's been well put by the others there, and then also I think sort of reflective of a national problem, which is that one of the things I think that we realized at the outset of the opioid epidemic was that the solution was not necessarily going to come from just being able to get everybody to an addiction expert. That some of the solution was going to have to come from getting providers that are already seeing people more comfortable with treating addiction, because the idea that we would just build more capacity in a bigger facility just wasn't going to happen fast enough, number one, and was probably not feasible. And what we've seen is that it's not so much about building another place for somebody to go to, but figuring out where people are already going to and figuring out if they're already going there, how can we incorporate this in? So that's been, and I know I have to give major credit to the state for both the Hub and Spoke grant and other grants that have really allowed for some more space to be created around which provider training can take place. I can say at the national level, that many of the accreditation programs that accredit physicians, for example, are looking at ways to basically mandate the addiction training become a more concrete part of the training programs, and then also diversifying the experience that providers get when exposed to treating addictions. Historically, in medical training, your exposure to addiction treatment was all on the acute care side. So you would see people at their worst, right? You never saw people, people don't come to the hospital if they're feeling well. People don't come to the hospital if they're doing well, by definition. So being able to kind of expand, I know certainly in psychiatry there's been a big push to have psychiatry residents exposed more to recovery programs and to seeing people in long-term recovery, seeing people in outpatient settings and not just in emergency rooms and ICUs, where a lot of providers get turned off from working with patients with addictions.
Thanks. Yep. Another question in the room.
Yes. Could the counties comment on coordination with the physical health plan, the Medi-Cal managed care plans? And then just Marlise, do you guys track the number of waiver docs operating and how many people that they actually are overseeing?
Do you want to, Marlise, why don't you answer that specific question first?
Good. Catherine knows my memory is short, so thank you, Catherine. Yeah, so we actually in California have a little over 1,000 waivered prescribers. The unfortunate piece is they're not all prescribing. We can see, we receive from our federal partners these lists on an ongoing basis. So we are doing some work on a different effort to be really reaching out and working with them.
Yeah, so on the work that we're doing with our local Medi-Cal managed care plans, primarily LA Care and HealthNet in LA County, I think the first step that we took was just making their leadership and their staff aware of the benefit and what was on offer, really, and keeping them educated about what we were doing, and then also making their providers and their beneficiaries, their members, know that this was available. So basically making sure that in their provider newsletters, in their beneficiary newsletters, at all their family resource centers around the county, that they're distributing that information, knowing that there's a number to call. And I think they've done a very good job of utilizing the new resources that I presented in one of my slides, knowing that there's a 24/7 call center, there are co-located counselors in the community, they can always call a provider directly. I think in addition, we have one pilot coming with LA Care, if the department is comfortable with it, that will make more streamlined access available to particularly those with alcohol use disorder who are frequent visitors of EDs, have kind of more streamlined access into our residential and withdrawal management facilities. So we're certainly trying to create more meaningful and streamlined connections where the need exists in their system, and to also, I think, make them just more generally aware of what the waiver offers and what we're doing to make it as impactful as possible. Because I think historically they've always said, we know you're there, that we know you provide treatment, but we really don't know how to access or what services exactly you can provide to our members. So I think a lot of progress is being made, but certainly a lot more to be done.
Jeff, do you want to comment from Marin County?
Sure. We're very fortunate. We've been working very closely with with our managed care provider, which is Partnership Health Plan, and in full disclosure, I also am a consultant with them and have been taking on more roles with them as well. Some of the concrete things that we've done, one of the things that we did was set up sort of a regular time that we were going to be meeting and sharing information about sort of how our program is going, what are the services that are available. On one hand, that's sort of one aspect that we've worked with them on. Another aspect that we've worked with them on is again, Marin County, it's a small county. We have the luxury of being able to kind of do outreach directly to some of the providers. So, for example, going out to the FQHCs and offering them information on how people get referred into the program, and then also having that reinforced by Partnership Health Plan, providing that information to the FQHCs, and then in particular, I would say, if I had to distill it down and say sort of where are potentially the areas of most fruitful collaboration with the managed care plan, one is around the FQHCs and around kind of when we go to the FQHCs and we were able to tell them, like, listen, these are the things that the county is doing around substance use. Here are some of the things that you could potentially be doing as well. Some of these things, like buprenorphine, for example, don't necessarily require a referral out to one of the contracted AOD providers. That could be done internally, and we can help you do that. So I've partnered with Partnership to provide trainings. I think at this point, I've done like 13. I'm going to toot my own horn here for a second. I recently found out, because I'm at the AAAP conference here, that I'm their number one. I've provided more waiver trainings than anyone else, apparently, in the past like 18 months. So being able to offer those services and being able to do that hand in hand with the managed care provider, I think gives it a lot more leverage and gets people's attention a lot more strongly. The other area of great collaboration or areas of fruitful collaboration around the emergency rooms. In Marin County, we don't have county operated hospitals, So in other words, they don't fall under the umbrella of our Department of Health and Human Services. They are administered under their own separate boards. But they do receive funding for their Medi-Cal services via the managed care program. So being able to, again, kind of go hand in hand in and into the emergency room, into the hospital, to be able to try to change hearts and minds around sort of what's possible internally. Again, I've found that it goes a lot further when I've been able to do that hand in hand with partnership. And fortunately, partnership's been very collaborative around that. The third area of fruitful collaboration, which hasn't entirely materialized yet, but I think is the area that we're going to be focusing on a lot in the next year or so, is around criminal justice. Even though, services provided within custody, for example, are not necessarily covered by partnership or, for that matter, by anybody, being able to look at ways that we could partner around providing services sort of everywhere around the custody or around criminal justice setting, and again, in an attempt to kind of bend the cost curve and the utilization curves. Again, I can speak and carry a little bit more weight and get a little bit more leverage in some of these institutions, doing it hand in hand with our managed care provider.
Thank you. And I was just going to say that you can't see the room, but we are all really impressed by how many waiver trainings you have done. So that was the part. I'm killing it up here. I'm just you were. We want you to know that. Okay, I think we have time for probably just one or two, so we'll keep the questions and the answers pretty brief so we can get them in.
So I'm glad that Kim asked about prescribers, and Marlies, you touched on this. A percentage I saw a couple of months ago was something like 23% of physicians who are getting waivered aren't providing services. So is there anything that the state can do, or from from a county perspective, that the county can do? I know we're hearing from the doctor online that he's doing training. So I don't know if it's more on the associations to make their providers more comfortable, or just what's being done around that.
Yeah, I think it's, thank you, Reyes. I think it's everybody's job. I think everyone has a role in it, and I know at the state level, we've really been fortunate to have some federal dollars come down through grants for the opioid epidemic, and we have been focusing on opioids, and then also, as needed, branching that out into SUD. And the waivered prescribers are one of them, but also we have a great ED Bridge project where we're training EDs how to prescribe buprenorphine and then hand them off into the community. There's a lot of great counties that are embedding counselors into the ED site, so that really helps get the EDs kind of used to substance use disorders, and really it's a lot of each one reach one. So we have quite a few projects currently underway that we're going to be rolling out in 2019 around this effort as well, to get those doctors that are already waivered prescribing more, and then to get new folks on board.
There's not another question in the room. I'm going to ask John.
Can I just add I'm sorry to jump in. I just wanted to add on that point, because that's a point that's actually pretty near and dear to me, because training people obviously is one thing, but we've found that that's not sufficient. So on one hand, it's necessary. You need to get trained, but it's not sufficient. And if people want, I actually participated in a webinar this past week where we talked a little bit about some of the range of services. I know Marlies, and many credits to the state for helping to facilitate technical assistance or grants that are geared towards providing technical assistance. In addition to that, sort of at the federal level, and I guess at all different levels, a number of the professional societies and a number of the professional organizations are also providing basically peer mentoring. And I won't go through all of them, but for example, if a provider gets waiver trained today, they could apply for a mentor tomorrow and be connected with a living, breathing person who could then help coach them on sort of getting them through some of the logistics of how do you start somebody, how do you maintain them, and get a little bit of that support and supervision, because in actuality, that's how medical education works. I mean, we go to medical school, we get book learning, and then we go into the wards and we get supervised person-to-person training. So we're used to, as physicians at least, we're used to learning in that model.
Thanks. Okay, one more from the audience here. Yeah.
Thank you. I just was wondering if residential capacity has been an issue for recovery, detox, some of that aspect.
Great question. John, do you want to comment from Los Angeles?
Sure. So at this point, I think we are glad to report that we do not have an issue with residential capacity. That said, obviously, certain groups are, I think, more in need of services than others. So certain providers have different capacities and skills to serve different people. And so we sometimes, I think, for certain groups or in certain parts of the county, struggle with certain types of capacity for groups with special needs or people who speak a specific language. But we do have beds available in the network. So, and we're not allowed under the waiver to have a wait list. So I think we're happy to report in that or in that specific metric that we have capacity. And I think the key to this was that we no longer have a strict contract maximum for our providers because Medi-Cal's an entitlement, and we're able to purchase many more beds because of the more generous financing under Medi-Cal and the significant federal financing made available through the Medi-Cal program, particularly from the from the federal government. So we're able to purchase a lot more beds than we were previously, so that if a residential facility is DMC certified, we can buy all the beds if the provider is able to make them available to us. That said, I will say, since you raised withdrawal management, that is a particularly scarce resource in our delivery system. We are developing a rate for inpatient withdrawal management in 2 of our facilities that offer inpatient withdrawal management above residential withdrawal management to make more of those beds available. But it's something we're working on and is a particularly acute need in our system.
And Marlise, I think since we're pretty much at time, I wonder whether you can kind of bring it all home. You know, when you look at this program, and you've worked on this for a long time and worked in this field for quite a while, what's your vision? Not specific to this waiver, but can you talk a little bit about where you hope we'll be at the end of this waiver period, and what you see really the big change being for the Medi-Cal program and for the people of California?
Yeah, I mean, if you would have asked me that question at the beginning, I wouldn't have thought we were where we're at today. And I do want to just acknowledge folks here that are on this panel and other counties that have thrown themselves into this effort. I mean, there's been such a outpouring of folks that are really dedicated to individuals with a substance use disorder. And so it's so exciting to see that we've been able to set the stage, and the original folks that put these ideas together were told from numerous people that it would never happen, which is always exciting for me. It's like, ooh, I want to do that. I want to do that more. And so we're at where we're at today. I do want to express for those counties that are not in, it's because the state has put these counties through such a rigorous process to get onboarded and into the answer with the access. They have to do access maps and looking at penetration rates and really ensuring that when they turn on the light switch and come on board, that they can serve folks. Because we really wanted this to be a structured system and truly organized. And so we really want to continue to bring the counties on board, and we've been assisting them. And so really seeing for the rest of this waiver, getting our counties, all of them up and running, and then really testing it out. I mean, we're really still at the infancy of this. It's really only been a little over a year for some of these counties, but I hope you've enjoyed today hearing how far they've come. And I really want to acknowledge all the work that they've put in and the providers. And if you really understood how much work it's taken, you'd be really blown away, because it has just been huge shifts occurring. We didn't just do one small fix in California, and some of the states are doing that. They're taking one part of their system. Nope, we decided let's do all of it at once. Because quite frankly, to make a real system shift, that's what we need to do. And so I really see from this point on, we'll continue to do what we started and then start really reaching out even further into some of these other systems to see where our folks are, whether they're justice involved or whether other settings, so we can reach and help them as well.
Thanks. We're going to end now. I want to please encourage everyone who's here in the room to fill out the blue evaluation form in your packets. We really use those to try and make these briefings better and better. We're very grateful for your participation. I want to thank our speakers, Jennifer Kent, John Connolly, Jeffrey DeVito, and Marlise Perez for being here with us today. Thanks to all of you for coming and for joining on the phone or joining via the live stream. Thanks again, and please reach out to us at the California Healthcare Foundation if we can be helpful with more information. Thank you very much.